Alrighty, for those that are online, we'll watch this later. Go ahead and sign in using your phone. Today, we're going to be going over lots of assessments and procedures. I guess, but first concepts. These are pretty much here are just the different ways that the rupture membranes can occur. And sadly, after this, it's probably always going to be written in a abbreviation. So the rupture membranes can be spontaneously or artificially. Spontaneous would be like it just happens naturally. The artificial would be if it's performed, it's just artificially ruptured, kind of makes sense. This is usually by a physician though, and sometimes you might even get to see this, so it's pretty cool. Of course, PROM, premature rupture membranes, that's the one that's a little a red flag. If it was to rupture or leak any of the amniotic fluid before the onset of labor, and could be at any gestational age. So I guess if they did it early, you would want them to go in and they might have to stay on bed rest with some, they're probably gonna get in betamethasone and stuff as well. It says here, it can be spontaneously or artificially, of course, but it doesn't always happen before the onset of labor. Most of the time it is not. If this occurs, about 80% of women will go into spontaneous labor within 24 hours. Yeah. Lacerations, this is when we're talking about like a episiotomy or maybe they didn't get one and this happened during the laboring process. I would say just know that the higher the degree, the farther it is going towards their rectal mucosa. Not sure if this was ever a question, but beta could be, and let's hope it'd be an easy one. Once we cover all this exam's content, I'm going to try to make a lot of, I wouldn't say like, I'll try to make a lot of documents that can be possible questions. So we can really try to practice applying this stuff, because sometimes it's like, oh yeah, but then when we get on a question, it's like, oof, it's how to distinguish answers. So this would probably be something she goes over next week, but we have pain management. We have the different types. We also do have advantages and disadvantages. We're going to be on this slide for a little bit, but starting out, the stuff that I've seen on a lot of questions would be when we're talking about the spinal headache. Okay, things to remember: maternal hypotension usually occurs with an epidural. So we're going to, preload them with a lot of lactated ringers prior to the administration. The epidural often results in an assisted delivery. And I'll talk about this in a second with the effect it contributes to a lack of effective pushing, because they can't really know, it's all numb down there. They don't know when a contraction is really occurring. Sometimes if it's a lot of pain management going on, and they have a risk for the spinal and epidural headache. Spinal fluid comes out of the needle. Fluid imbalances do occur. I'm going to pull up my little book that we have here. There's a lot of very helpful, so I'll just read from it. Over the page, it has some of this. Before we're going into pharmacological pain management, there can be non-pharma, some people want to do it all natural. Some of the things we're going to do non-pharmacologically would be position changes to decrease the weight of the fetus on the area of the most intense pain. We might do hydrotherapy, so water therapy, by standing or sitting in a warm shower or reclining in a bathtub. Maybe some breathing techniques can also be done to prevent them from just holding their breath. Kind of like when someone lifts weights, they're just going to hold their breath. That's not the safest way. We want to make sure that they're facilitating oxygen exchange. That's just kind of what we need to make sure they're doing. We might even help them with some relaxation measures, with a massage, maybe some therapeutic touch or even verbal instructions as well. So yeah, there's that. To find out what is the most important step to stay. I don't want to say too much. Within the epidural block, this, of course, we have what's on the chart right here, but I also have some more information. This is kind of the advantages of an epidural. Of course, that's the one that everyone associates with the most excellent pain relief. We are able to redose medication into the epidural catheter if possible. This one usually coincides with no neonatal respiratory depression, so that's good. This one may provide a few hours of postpartum pain relief as well. We do have some disadvantages though with the epidural. Like with everything else, we have disadvantages. The time it kind of takes us set up makes it undesirable for rapidly progressing labors. So pretty much what that means is if we have a patient who's been saying, I don't want to have an epidural, but then all of a sudden the pain is just crazy and they ask for one, we probably can't even give them one. So it's all about teaching. And you as a nurse have to be able to assess when is the right time to give them that pain medication. Of course, they will talk to everyone else as well, but we're kind of advocating for them, saying like, hey, this is the beginning, it's going to get worse, and we don't want to make it to where you can't get the medication. This one usually causes numbness of the lower extremities, limiting mobility. Of course, a lot of times, whenever we're giving an epidural, they're probably going to get a straight cath. And you as a student nurse can do that, so ask to do that. This will decrease contraction frequency and intensity, thus requiring pharmacologic augmentation. And that word augmentation, we're going to get to in a second, but that means just progresses the labor. So they're not able to feel that contraction. So we need to make some kind of stir that up a little bit. The contraction is hard to detect and may require use of an intrauterine pressure catheter. Little to no urge of a push is felt. I mean, just things that you would kind of think of when they can't feel their pelvis downward in a way.
What do you do with it?
We're kind of telling them, we can see how last week we showed the acme and the peak and stuff like that, working them through that and telling them whenever they can relax, it's gone, you can relax for a little bit. All right, just get ready for another time. And that's kind of what they would do.
So like they can still first, even though like they've lost feeling?
Yeah, but the 2 times that I saw an epidural, honestly, they felt it. They still felt it. It wasn't like a painful feeling, but they still felt the pressure. So they were able to still feel it. And it was fast. So it's still in my head. I can't fathom really a long 24-hour delivery process, because the ones I've seen personally are always really fast. I don't know. That's the way it lied for me. And I wish I was in there more, but with the freeze, I wasn't able to go to much clinical. I only went 2 days in every unit. So it's still really cool though, but all right. So that's with that. Whenever it comes to the local, think of it as it's just local into the fat tissue. It's probably the one that's the least important. As we get into the 4th one here, pudendal block, I'll work on what that kind of is here. That's a local agent injected into the lateral aspect of the cervix. And there's a picture here that makes it very helpful. This is what we have right here. It's on the lateral outside, right over here. But the advantages of this are its rapid onset of pain relief, no neonatal respiratory depression. It can be given during the transition phase. So if the patient can't get the epidural, this is probably what they're going to be getting. It's a relative ease of administration as well. This one, of course, disadvantage again. They may feel a decrease or no urgent urge to push. Systemic absorption can occur as well, so we have to kind of monitor for bradycardia with this pudendal block. Just the baby's heart rate, of course. Going into the local infiltration, the local agents are given into the perineal tissues to provide pain relief for maybe an episiotomy. Of course, that's before with the ripping or the cutting, or repair or suturing of lacerations. So if they lacerated and we're going to repair that area, we're going to make sure that it's non-painful to them. This one with the local, the advantages would be it's easy to administer, provides a few hours of postpartum pain relief. The disadvantages, a re-injection may be needed to obtain a complete anesthesia with extensive lacerations or maybe a large episiotomy. So we could even be thinking of these pictures here. Of course, this is during the labor process, but if they had, an episiotomy, we're going to give them probably a local agent as we suture that, or just as we kind of work through that. Okay. Harold will probably speak more on the difference between epidural block and a spinal block. But we have it right here. The spinal is faster. The spinal blocks are more commonly used for shorter, simpler procedures, while epidurals are used for longer ones. I think the one C-section I saw was with a spinal block. Yeah, right here, C-sections. This is into the fluid of the spinal canal, while as an epidural is it's all the way up to, but not inside the spinal column. And these pictures would be more helpful with that. So the spinal goes into, the epidural is just outside. That's what that would be. Pretty cool. I think that's it for that. This is what we're going to be talking about next. These are all of those assessments and things like that are going to be on that pre-exam prep sheet. So pretty much today's entire SI session, you're probably going to want to handwrite this information later on that prep sheet, because I tell you, I handwrote it and it worked. A lot of the stuff that I'll try to hit on will kind of show you what could be tested on, but also the differences between the two. And this is just a really cool picture of this is a cool picture of the kind of just thing in the picture, but we're going to focus on all these things. Big takeaways to focus on would be what is a screening, what is diagnostic, and the trimesters whenever they're done. And some of this is exam one stuff. Of course, HCG testing. The purpose of this is determine the presence of pregnancy. Of course, if it's increasing, it's you are okay. We're probably going to do this test if indication, if they have of course, if there's suspected pregnancy, maybe they have a history of spontaneous abortions, maybe they possible ectopic pregnancy, because with that ectopic pregnancy, remember the HCG levels are just through the roof, and there could even be having a lot of vomiting occurring. The method, this is just an maternal blood serum, urine, two values are drawn 40 hours apart, and the second. So we're trying to see if it's increased from that first one. 2 days go by, isolating again. Positive or negative, or the increase or the decrease. The interpretation of this is the doubling of two quantitative beta HCG levels indicate viability. Levels that have remained stable or fall indicate a spontaneous abortion, also called miscarriage, or maybe an ectopic pregnancy. Risks would be the infection, low risk to mother baby to obtain this test. Waiting between tests can be a very anxious time. That's pretty much that. The quad screen, also called quadruple screen, is the test that we're doing. We're interpreting pretty much, are they high or are they low? Also called the alpha fetal protein. The purpose of this is to kind of see if they're having maybe any risk, maybe a genetic risk. The indications for this, it should be offered to all women because this is going to be just kind of a screening test. This should be offered to all women, strongly recommended for high-risk moms. So pretty much a mom is older than 35. Maybe they have a history of this as well. This is the method. Big takeaways here, though, are the 15 to 21 weeks. And the one thing I'd recommend to do whenever you do your chart is to highlight the weeks, because those would be very helpful. Understanding that they kind of go into groups as well. Of course, this is on first semester, first exam stuff, but a high level indicates maybe a risk for a neural tube defect. A low alpha fetoprotein level is a risk for Down syndrome as well. All right. If this has, I guess we're going to that a little bit, because the next test we're going to talk about, I think, is the cell-free DNA. The cell-free DNA tests are indicated to kind of see if we have a genetic disease. So indications of this would be advanced maternal age, so plus 35 plus. Maybe have an ultrasound abnormality, a history of previous fetus with that word, aneuploidy, maybe just have a history basically. This is done. This is not a diagnostic test. This is I would say a screening test. This is going to be done at 10 weeks. The results of this are going to be positive or negative. Negative indicates you are unlikely for the trisomies 13, 18, and 21. A positive indicates a risk. This is not diagnostic, so we're saying it means the risk of the abnormality. Abnormal results would pretty much say, hey, let's do some further testing. Pretty much that. This does not screen for neural tube defects. That's what the NTD means. So that's that. Okay. Going to genetic testing, we have the actual invasive sampling. So we have the chorionic villi sampling. The purpose of this is obviously if we just need to get more invasive, maybe that screening test was positive. Indication of this would be, of course, advanced maternal age, a previous child with the abnormality, or maybe the parent is a carrier of a chromosomal disorder. This is, it's in the word, so this was very, very easy to remember, but it's a sample of the chorionic villi, sampling, of course, from the edge of the developing placenta at 10 to 13 weeks. Okay. The results of this would be, takes about 2 weeks, but this can detect Down syndrome, Tay-Sachs, and hemoglobin opathies as well. This is diagnostic. The risk of this would be spontaneous abortion, but it's a very low risk. It's still a risk though. But maybe they have a failure to obtain the tissue. Maybe we accidentally rupture the membranes. Maybe we have them leaking amniotic fluid, or they're having some bleeding or spotting. Stuff that sounds pretty scary, but we have to teach them that if this was needed, the positives kind of outweigh the negatives with this. Okay. A little more information on this. Page bookmarked right here. Of course, this involves collecting a small specimen of the tissue from the fetal portion of the placenta for fetal genetic studies. This is done approximately about 10 weeks gestation. Women who are 35 or more years old, or who have had a frequent spontaneous abortion, maybe fetuses with chromosomal abnormalities. Of course, it's already there. Advantages of this would be when compared to the amniocentesis, this includes an earlier diagnosis and an earlier return of the results. This test can be performed at 10 to 12 weeks gestation with results in 1 to 2 weeks. Okay, that's pretty much what that would be. Follow-up teaching includes signs and symptoms of a complication of this to report to the physician, or telling them when the results would be available. That's pretty much that. Yeah. Okay. Amniocentesis for karyotyping. This is, of course, done later at 15 to 21 weeks. The purpose of this is to assess fetal health or maturity, determines also genetic abnormalities. The indications of this are the same things, AMA, other defects or history. The method of this is a sterile needle is inserted into the uterine cavity through the abdomen to obtain amniotic fluid. So amniocentesis, think of thoracentesis, same type of thing. The results, if this is normal, it's going to be no genetic abnormality. If it's abnormal, it detects a gene or chromosomal problem of birth defects that involve the spine or the brain. The risks of this are going to be transient vaginal spotting, maybe cramping, amniotic fluid leakage, needle injury to the fetus, or risk for fetal loss. Okay. This next step we're going to go over is pretty much stuff that you've been tested on already, but starting off is the non-stress test. This is just to monitor the fetal heart rate. This test is an assessment of fetal well-being. It's usually performed at around 23 to 24 weeks gestation. This is non-invasive. It's easily to interpret, and it can be performed in an outpatient setting, and it's usually at a low cost. The non-stress test is a good indicator of fetal well-being. The disadvantage of this would be a high number of false positive results caused by fetal sleep cycles. Maybe some medications cause that as well. The non-stress test is not a good predictor of poor fetal outcomes. So obviously we go into the stress test later, but we have a reactive or non-reactive. Whenever it comes to the findings, the test is considered normal reactive if there are 2 or more accelerations of 15 beats per minute lasting for 15 seconds over a 20-minute period, or a 10 beats per minute lasting 10 seconds if the pregnancy is less than 32 weeks gestation. If these criteria are not met within 40 minutes, the test is considered non-reassuring, non-reactive, and further testing would be indicated. So I guess what you have to focus on with this is what this criteria is, knowing that it's done at 23 to 24 weeks. That's the only thing with this. Okay, the contraction stress test is this assesses the ability of the fetus to withstand stress of uterine contractions. Obviously in the name, contraction stress test. And it is a means of evaluating placental capacity for oxygen, carbon dioxide exchange. Because during contractions, there is less blood flow to the fetus. This is used to predict if a fetus may not be able to make it through the stresses of labor. And this test is done beyond 23 to 24 weeks gestation. Okay. We do have the negative normal, positive abnormal. The findings of this are when a pattern of at least 3 contractions of 40 to 60 seconds duration and a 10-minute time period is obtained, the fetal heart rate is assessed, and the test is reassuring negative. If no late decels occur, the test is not reassuring positive if there are late decels with at least 50% of contractions. So the same type of criteria. I would say just go back on the recording and write down what we, and you can also take pictures of my stuff if you need to as well. I have the page bookmarked. We have the vibroacoustic stimulation test, VAST, also called. Purpose of this, sort of assess response to stimulation. This is kind of like the little stimulating the baby type of stuff. Indications of this maybe be hypertension, diabetes, maybe the baby's just really small, or that's what intrauterine growth retardation is, post-term or decreased fetal movement. I would say just read what we have on the method right there. The results of this would be an increased heart rate, or maybe a decreased heart rate, or maybe even no movement. And then for the interpretation, just see the method section right there. This is non-invasive and this is low risk. All right. Now for ultrasound-based tests, we have the amniotic fluid index. The real big thing with this would be probably the interpretation of this. But pretty much this is talking about how much amniotic fluid are there. This also tends to reflect kidney perfusion as well. So this measures in centimeters the quadrants of the stomach, splitting by the linea nigra. The results of this are usually 8 to 18, but we have these numbers here. If it is 5 to 6, that means polyhydramnios, or less than 5 to 6. Pretty much that O there, it means that it's not enough. Think about like hypo, stuff like that. If it is more than 20 to 24 centimeters, we have poly. Poly just means a lot. So, if it's ever like, it would be pretty easy, but if you ever had like an interpretation of this, what's poly or what's poly, type of thing like that, or maybe talking about, I'll try to find more information on this, but it seems like it's too easy to get wrong, but I wouldn't want you guys to mess it up. Because who knows what type of stuff of questions could be out there with this. So I'll try to find some. But yeah, I mean, poly means a lot, ollie, low. So yeah. We have the biophysical profile right here. This method is used to assess the fetal well-being at around 23 to 24 weeks as well. This determines score on 5 criteria, including the breathing, the movement, their body movement, muscle tone, heart rate activity, of course, and amniotic fluid volume. This is kind of used, of course, maybe they've said that they're having a decreased fetal movement, management of a intranuclear retardation, preterm labor, maybe they have gestational diabetes, so we're kind of expecting a bigger baby, meant to put hypertension there, but maybe you just have any of the high risk sides of pregnancy. Or premature rupture membranes, that's what PROM would be. This score here, okay, what's right there? Normal amniotic fluid is more than 5. The interpretation would be abnormal if less than 5. But in regards to the entire biophysical profile, the score itself ranges from 0 to 10. A score of 2 is given if the criteria is normal. A score of 0 is given if the criteria is abnormal. A total score of 8 to 10 considered normal. A total score of 4 to 6 is interpreted as abnormal, possible, and a score of less than 4 may indicate a need for a delivery. Okay, and here is that. You can picture this. But I don't think that's this is the chart right for that. For everyone online, I will post that chart of the biophysical profile ratings. Not sure how if it would be tested on, but you never know. So I would always I'll just get it posted for you on the Google Docs. Estimated fetal weight. This is of course used if maybe we have a expecting big baby or a very small baby. We have to kind of just estimate it. Macrosomnia would be big baby. IUGR would be I suspect a very small baby. The method is this, or connecting 2 elastic belts placed around the patient's abdomen using an ultrasound wave. The results should be normal, heart rate without decelerations. Interpretation of this would be no decels. This is non-invasive, but hard to track if not put on in a good spot. Alrighty. All right, timing of delivery here. Of course, we have the fetal fibronectin test. This can predict an absence or maybe a presence of preterm birth. This test is used to determine if our mom was in preterm labor. The protein that acts as the glue during pregnancy attaches the amniotic sac, the fluid film membrane, then cushions your baby in the uterus. A negative predictive value is good, a positive is bad. Lots of false positives, okay? So pretty much if they have a history of it or maybe a suspected, we're gonna go ahead and just put the swab on there. And then interpretation again, negative means that the fetal fibronectin is still intact. The positive indicates a risk for preterm labor. And I have it color coded already there. So this one's like, no, like a negative me would be, no, you're not going to preterm labor. Positive would be, yeah, I guess that's what best way to kind of explain what that would be. When we're talking about LS ratio, you won't have to know what those LS actually mean, but it's about assessing. Pretty much this is always going to be with lung maturity. If the ratio is not 2 to 1, we're probably going to give betamethasone, steroid to kind of help boost that production of surfactant, also called celestone, CELESTONE. So if you see those words there, that's just what that would be. Maybe the mother's diabetic, got high blood pressure, premature rupture membranes, anything like that. We're going to go ahead and assess, how the fetal lung maturity is kind of going on. It says risks here. Diabetic moms give a higher risk of false positive. Blood or meconium can also give false results, like if the baby was to have a meconium aspiration. When you see LS, think of it as, is the baby creating surfactant? And of course, it means lecithin, sphingomyelin, but Okay, other tests here. We have the fetal movement counts. Starting about 28 weeks, they're counting, the mother will always count. This is indicated in all pregnancies. The mother should count the kicks she feels using the Cardiff count to 10 method. The results, about 10% of the time, making movements between 28 to 38 weeks. And after 38 weeks, the movement should be increased. Interpretations say less than normal may indicate an issue. The risks for this, low risk, maybe they could be inaccurate. When in doubt, have the mom come in. The baby could just be in a deep sleep, anything like that. But usually they're going to count their kicks, and the mother will know when things are off. It's her baby. She's the one that's with it every day. So she'll kind of say, it feels off today. Haven't had the baby kick, things like that. Okay, next is kind of a flip. Going into ultrasound, we have these 3 different trimesters that it's kind of broken up on. Within the first trimester, we're talking about determining fetal age, maybe if they have any potential defects. Also, how much amniotic fluid are they having? Are they OLI, are they poly, or are they OP? This is indicated always for all pregnancies, done at every prenatal visit. Of course, the interpretation would be abnormal result. We're going to warrant further testing. Within the second trimester, we're looking at growing. How are they growing abnormally, normally, based on their age? Are they going to be, macrosomatic? Are they going to be very small? Are they having a proper fetal heart rate? Amniotic fluid, of course, is looked at again, and we're going to know the sex. During the third trimester, amniotic fluid analysis again, and of course, just progression. Too much, that's what it is. Okay. The amnesia here detects ruptured membranes. This is indicated whenever a Premature rupture membranes cannot be confirmed by other methods. The sterile swab is inserted into the vagina, detects presence of PAMG1. A risk of this would always be infection because we're putting something into a different environment. Of course, alternative to this could be a nitrazine paper. We talked about it last week, but benefits of this are going to be it's quick, it's easy, and it's accurate. Okay. Within the nuchal folds, the purpose of this would be to determine a risk for chromosomal disorders. Maybe they have a history already. Of course, that would be an indication. Or maybe they have a family history of chromosomal disorders within just their family itself. The method of this is it assesses, an ultrasound assesses the accumulation of fluid between the posterior cervical spine and the skin on the neck. The results of this are going to be measured in millimeters. More than 33 millimeters indicates an increased risk of trisomy 21. That would be the only thing here. This is performed usually at around 11 weeks to the end of the 13th week. So pretty much right at that first trimester time. 11 weeks and 1 day, so the beginning of the 11th week to the 13 and 6 days, the last day of 13 weeks. Okay. Now, procedures for labor interventions. We have a lot of stuff to kind of go on here. But I would say, okay, this is pretty much if the baby is not, I know we had this question last week, but if the baby is not in the cephalic presentation at 38 weeks, we're going to try to change that. Indication that this would be maybe a brief presentation if they're at a transverse or an oblique lie. The method of this is the physician uses what's called the Leopold's maneuver to find the back. They're kind of palpating, or assessing. The physician applies pressure to the fetal head and the butt so that the fetus completes a backflip or a forward roll. This is done externally. Benefits of this would be to decrease the risk for a non-vertex birth or C-section. The risk would be maybe that entire back flip or front flip would be enough stress to cause the baby maybe needing a C-section. Maybe the baby doesn't turn. There's of course a low risk of causing some bleeding. An alternative, of course, would just be a C-section if the baby doesn't turn. But yeah. With that, I would say that's kind of that wouldn't be really with this, because if the cord's wrapped around, I'm pretty sure we'd just be doing a C-section. It would be like a warrant, and you would see that on the fetal heart rate monitor. They'd probably be into some T cells and stuff like that. These two words here are going to be for sure very important. We have augmentation, which means kind of continuing the laboring process. And then we have induction. The word you frequently hear is someone's going to be induced for labor. This is starting the laboring process. And induction is the starting of the contractions before the spontaneous onset of labor, with or without the rupture membranes, for the process of accomplishing the birth. Okay, with an augmentation, it's going to be progressing the labor, stimulating the contractions when a spontaneous contraction has failed to progress the labor, when a cervical dilation or the descent of the fetus have failed. And we have a lot of different methods here, but we have a huge list. Maybe it's by stripping or sweeping. Okay, maybe it's by stripping or sweeping. Maybe it's by infusing more oxytocin. Oxytocin is that med given IV to achieve a desirable labor pattern with strong contractions that result in a cervical dilation in the fetal descent. And we just, of course, have a lot of these words right here. Okay, the one that students always laugh at is sexual intercourse. The female orgasm stimulates uterine contractions and male ejaculation. Contains actually a rich source of natural prostaglandins. This method is not, of course, used to augment it, but more into induce labor. Sorry. Of course, we have nipple stimulation, but yeah. I know before in the prenatal experience, there were those like the B's and G's and the E's, those things you want to stay away from. And we could start taking them now because we're trying to induce that laboring process. So review the uterine stimulants. We could do an enema to be a result to kind of really release that prostaglandin at the correct site. And yeah. Some more methods would be like an evening Primrose oil. This contains a fatty acid, which is converted to the prostaglandin compound used after 38 weeks of pregnancy. Well, my little sheet right here. Some notes that I took yesterday. And guys, when we're talking prostaglandins, these are used to soften the cervix and promote dilation to assist the vaginal delivery. So that's kind of what that is. Anytime we're talking prostaglandins. Yeah, I mean, this goes back into like the Bishop score. The higher score indicates a rate of a successful labor. The client needs to avoid prior to any administration of a prostaglandin. Prostaglandin gels, Cervidil and Prepidil. It could be placed posterior vagina and is left in to provide a really slow release of this. They're easy to use and associated with the need for a less oxytocin during the laboring process. Okay. This med here is going to be pretty important. Cytotec, misoprostol. It's probably going to be on your care plans, but this is available as a tablet. It's inserted into the vagina or can be taken orally or sublingually. Cytotec is a peptic ulcer disease drug. Off-label would be as an induction of labor, more effectively than oxytocin or prostaglandin, and it's also a lot cheaper. Typically, women deliver within 24 hours. It's also associated with lower numbers of C-sections as well. Okay. It's a balloon catheter. I would say just read that right there. But the real big one here would also be next, the AROM, the artificial rupture membranes, done with an amniotomy. This is whenever we have it's very common, performed by, of course, your OBs. At least 2 centimeters of surgical dilation is needed, and this can be performed to induce or augment labor. The amniotomy is less costly than other methods of induction. Okay. We have risks, benefits, and alternatives. Risks are maybe we have a non-reassuring fetal heart rate. Maybe we accidentally hyper-contract them. They're having just lots of contractions. Maybe they might have an abruption placenta. Maybe they have fetal hypoxia going into late decels. Maybe they have a rapid labor. Rapid labor would go along with maybe a laceration or even a uterine rupture. Benefits of this would be, we're of course getting them some contractions going. Maybe they can even, if they're having an induction, they can even choose the day to begin the labor process. So that's pretty cool. Then they can eat a huge diet and get some good rest, and they'd be really well prepared instead of being awake for 20 hours before going to the laboring process. Alternatives are nipple stimulation, herbal remedies, positioning, and natural birth. Okay. All righty, I'm going to go ahead and back into it. This is here cervical ripening. We're kind of beating it more, but some of the stuff we're going to go on we just have it laid out like this, so it can be easy for your prep sheet, okay? This is, of course, softening and effacing, thinning, wrapping the cervix needed for the dilation process. Maybe they have an unfavorable cervix, or maybe they're used at or when inducing labor. We're going to give the misoprostol cytotec, the prostaglandin agent. I've already talked about that is to soften the cervix and promote dilation processing. Okay, benefits of this would be to soften and ripen the cervix. Less oxytocin is needed. Maybe a shorter labor is also what we kind of want with this. Risks, of course, are uterine hyperstimulation, maybe a postpartum hemorrhage because they had a very fast labor and just lots of bleeding occurred. Uterine rupture, maybe a non-reassuring fetal status as well. If all things fail, C-section would probably be what's going on. Okay, amniotomy. Purpose of this would be a artificial rupture membranes. Indications with an induction or augmentation. We now know what those words are. If it's a starting or a continuation of the laboring process. Method is an amnio hook is inserted into the vagina through the cervix and against the amniotic membrane, creating a small tear. The benefits of this would be a shorter labor, a decreased incidence, so decreased occurrence of C-sections. Of course, we even can evaluate the amniotic fluid. Of course, if we're being invasive, we do have a risk of infection. We have a dangerous risk of a prolapsed cord, a fetal injury, maybe the hook cuts the baby, lacerates the baby. Just risks, but yeah, someone trained and very safe. Alternatives would be a natural rupture membranes, the spontaneous rupture of membranes. So yeah. Amnio infusion. This is purpose of this would be increase the amniotic fluid volume. So maybe they are olighydramnios, and you want to make sure they're getting some more amniotic fluid to decrease the pressure on the umbilical cord, increase perfusion to the fetus. Indication of this would be oligohydramnios, meconium. They have the presence of meconium, and we want to add more amniotic fluid to kind of dilute it. Okay, maybe they have variable D cells by increased amniotic fluid volume. The method of this is a warmed, sterile, normal saline or no lactated ringers solution is introduced into the uterus through the use of an intrauterine pressure catheter. The benefits of this are less cord compression. Things are off the uterus now. Off the placenta now. Increased amniotic fluid. Obviously, that's the purpose. The decreased cord compression has occurred. Prevents meconium aspiration as well by diluting it and making it a suitable environment. So yeah. Assisted or operative delivery are going to be an episiotomy. The purpose of this is to widen the vaginal opening to reduce the damage of the perineum from lacerations. So pretty much it's like a surgical cut to prevent it from tearing naturally. The indications of this would be a macrosomia, maybe a very large baby. If they are prima gravidis, so this is their first time. If they have an occiput posterior position, maybe a use of forceps. Our white mothers are usually the ones that might need this. Use of forceps as well, typed it twice. Maybe also shoulder dystocia. So if they have the shoulder, that's going to make it more wider. So that's what that would be. The method of this is it's performed with a sharp scissor that has rounded points just before birth when 3 to 4 centimeters of the fetal head is visible during a contraction. The benefit of this is it protects the bladder. It's an easier passage for the fetus. It reduces perineal damage. It protects the maternal bladder and protects the vaginal wall. The risks are infection, of course, is cut, bleeding, maybe a tear past the incision itself. Alternatives are allowing the body to tear naturally. Laceration is natural. So, 4 steps of this. I can pull the picture of what this is. As we talk about forceps, this is what we are kind of discussing here. So let's go into that now. Okay, forceps are to assist the birth by providing traction or rotating the fetus to an occiput anterior position. This is indicated in a breech presentation or maybe a condition that threatens the mom or fetus that can be relieved by birth. The method of this is negative, as the low forceps placed in the fetal head at a +2 or below position, and the head is rotated to the occiput posterior. This is what this would be. Sure. The benefits of this will be a faster birth, a less danger to mom and baby, maybe even creating a more favorable position for delivery. Risks, we have the ecchymiosis or edema where the forceps are used. We can have a caput succoideum, maybe even a cephalohematoma, which is where we're talking about blood there. Succoideum meaning fluid. Maybe they might have a lower apgar, a retinal hemorrhage, a coronal abrasion. Maybe they have some trauma. Usually whenever you see a baby that has forceps, you're going to see them having redness. Okay, and then going into next, we have vacuum extraction. There was a picture. Okay, vacuum extraction is where we can get the very much, sometimes you'll see it, and she'll show you in class. It can make like a little cone head. It's pretty much another form of assisted delivery, but let's go into that. Okay, vacuum would be to assist with birth of the fetus by applying suction to the fetal head. An indication of this would be a prolonged second stage, maybe a non-reassuring fetal heart rate. The suction cup is placed on the occiput of the fetal head. The pump creates negative pressure. The physician applies traction and assists the baby out while mom pushes during her contractions. This is an assistance in vaginal delivery. And the goal of this is to avoid a C-section. Maybe it's been taking very long. No fetal descent has occurred. We have some risks with this. We have scalp injury. Maybe they have a bruising of the suction, a hematoma, cephalohematoma, which is the collection of blood on the head. Neonatal jaundice, because of, well, this is later stuff, but cephalohematoma is usually always a risk of neonatal jaundice because all that blood will break down, like that. That's where we get jaundice from. Maybe a fractured clavicle. Maybe the shoulder wasn't in a position that we don't want it to be in, and we just pulled them out, and that broke their clavicle. Erb's palsy, maybe even fetal death. An alternative of this would be C-section, and that's where we're going into next. A cesarean delivery, commonly called C-section, would be to have the birth through the abdominal and uterine incision. I could not believe it, but when I was younger, I didn't know that they cut the uterus too. Crazy stuff. But the indication of this would be we've already talked about it, but a placenta previa, active herpes lesions, maybe an umbilical prolapse within 10 minutes. So that's usually if they have a prolapse cord, you're going to take 10 minutes and go straight to the operating room. Maybe we have the other ones as well, but really these highlighted ones are the C-sections for sure. With a skin incision, either a transverse or vertical incision to pull the baby out. Commonly today, we are doing, I want to say it wrong. I would say we're doing transverse cuts now instead of vertical. I think so. We're going to do cut this way instead of this way. We do have some risks with a C-section though, is higher mortality rate than a vaginal birth, post-op complications, and infection. A C-section is a major surgery. It's a lot of times people sleep on it, like, oh, it's just C-section. No, it's not. You're in the operating room, you have the scrub nurse, you have everything, and you're gonna like to watch it when you go there. Okay, we have incisions here. We have abdominal and uterine here. Talking about the transverse incision, The transverse incision is usually with a decreased amount of blood loss, chance of a subsequent rupture or a peritonitis. The transverse incision is easy to repair, although it does take longer. It's limited in size. You don't have to cut as long. It's a greater chance of extending lateral into the uterine vessels. The reason we call the vertical incision the low classic is because it's one that was used in the past, but we have learned that with VBACs, and we'll talk about VBACs in a second, but we've learned that with a vertical incision, that one could create more risk of a uterine rupture if they had to try later a vaginal birth after having a C-section. So pretty much now we're doing the transverse because it's we're looking at the future, low risk for future things. Within the lower uterine segment, vertical incision, also known as a low classic, this is used when we need to have a rapid delivery. Maybe they have a huge baby, maybe the mother is obese, a preterm fetus or multiple gestation. I was a twin myself, so my mom probably had that. We were C-section. This is indicated there's a presence of adhesions from previous C-sections, transverse lie, or an anterior placenta previa. Okay, with a classic incision, this is infrequently used now. This is usually going to correspond with more blood loss than a lower uterine transverse. This is more difficult to repair. This is an increased risk of uterine rupture with later pregnancies because the upper uterus is the most contractile portion of the uterus. I mean, just think about how your body would, I don't know, just think about like a surgery and all that. You're growing and you're growing and growing, and it just would possibly create a rupture as well. I went ahead and added this in. It's probably not in your PowerPoint, but when we see these words here, TOLAC and VBAC, TOLAC is a trial of labor after a cesarean. And it probably would be, for a patient who didn't have a classic, it'd probably be the transverse. And we even have VBAC, which is the vaginal birth after cesarean. Those are kind of exchangeable. Usually it's a trial. Hopefully we can make it a vaginal birth. The purpose of this was just to give an opportunity for vaginal birth. The indication of this is if they have a low transverse uterine incision, they have no uterine scars or ruptures, they have an in-house doctor, and anesthesia prepared if needed for an emergency C-section. The method of this would be a vaginal delivery with any assistance needed. The benefit of this would be if a mother wants to not have another C-section, maybe she wants to have a vaginal birth because she feels that might give her a more emotional benefit. She might feel that she was, I mean, you'll just kind of see it. When you go to clinicals, you're going to see that when a mother's having a vaginal birth, you know, she's there skin to skin after a birth, whereas if she's in a C-section, she might not remember a lot. She might have to, you better hope that the father that can really go and watch everything, because they're going to take that baby out of the operating room to go do its ABGAR, to go do its weighing and stuff like that, versus if it was in a vaginal birth, they're doing it all in the room with the mother to watch it all. So it's just less of a memory thing, but of course, you know, sometimes you have to do it, and it's about safety. It's not about what is kind of wanted. So of course, this is why we get the vaginal birth after C-section to kind of maybe provide that for her. Risk of this could be, of course, a uterine rupture, uterine dehiscence, hysterectomy, uterine infection, maybe a maternal or fetal death, stillbirth, or a transfusion maybe needed with blood loss. The uterus is the smooth muscle and has a likelihood of tearing during the presence of contractions. That's what we have as well. All righty. Neonatal stabilization, all of that whole stuff has now ended. Now we're talking about the baby. We've already talked about the ABGAR here, but a perfect score is 10. However, a normal score is 9. there's one more that would be the definition of why. And it kind of goes, I'll draw it on the board. That would be acrocyanosis. It would be whenever we have blue hands and blue feet. So that would be the very reason why we have a common score of a 9 on the APGAR. Initial assessment would be airway, breathing, circulation, of course. The APGAR score evaluates the impact of the intrapartum events on the infant and the infant's ability to adapt to extrauterine life. This is immediate at birth, so we have to watch the clock. We have to give this at 1 minute and at 5 minutes. And those, of course, are different things here. We're looking at the color, the pulse, the reflexes of their grimaces, the activity, how movable they are, and the respirations. Whether it's a good, we want to have a good cry, because a good cry has a good respiration. All that is, they're letting out all the oxygen there. Okay, stabilization and resuscitation. We have to warm, dry, and stimulate the baby with blankets. You want to get all that fluid off of them. And so, maybe to skin. Remember to replace the wet blankets because we don't want to have them evaporate the heat loss. If the baby's not breathing up to 30 seconds, we have to start breathing for them. The positive pressure ventilation, or also called ambu-bag, or even a flow inflating mask. The flow inflating mask cannot provide 100% oxygen without a reservoir and power source. And this is just different things we have to cover. The continuous positive pressure ventilation until the baby is breathing or an advanced airway is in place, such as the trach. We do have the pulse here, the umbilical cord or auscultation. A lot of times you'll see it on both. So when you're looking at a baby, it's pretty easy. The pulses are fast. So it's pretty easy to count a baby's pulse by looking, of course, when you're doing the respirations, looking at the right of the chest. With a pulse, usually that if you look at the umbilical cord, it's going to be going the exact same beat. You're going to count it for 6 seconds and multiply it by 10. So it would just be so hard. You'd be like 77, it'd be really hard. So you're doing it for 6 seconds, counting it by 10. The heart rate less than 60, we're starting compressions. The heart rate more than 60, but less than 100, we're going to continue positive pressure ventilation. And I believe I had misspoke on last week's. So this is the criteria, but it's correct. I think I might have said 100 would be compressions, but that's what this is here. So less than 60, we're doing compressions, more than 60 and less than 100, positive pressure ventilation to give them more oxygen, pretty much. And of course, the APGAR score. We have practice questions from the past 2 weeks of info. Okay, we have a woman in her 40th week of pregnancy calls the clinic and says she's not sure whether she's in true labor or not. Which statement by the client would lead the nurses to suspect that she's going through false labor? Okay. You are correct. The answer would be B. And I'll show you right here. We have on the textbook here. So go back on the recording, remind ourselves what that is. But this question that we were talking about here was on the activity, the change in activity. This was saying that this is false labor because the contractions slow down with walking. That's what that one was. Okay. Yeah, so the first thing we have to know is we're still in the first stage of labor because we haven't delivered the baby yet, but it's all about which phase it's in. We're going to be in the late active phase of the first stage of labor. The rationale of this is late in the active phase of labor, contractions become more frequent, around 22 to 5 minutes, and in duration, 45 to 60 seconds. The woman's discomfort intensifies, she becomes more intense and inwardly focused. She absorbed she's also absorbed in the seriousness of the living process. Okay. Dilation of 3 centimeters. The cervicals effaced 30%, and contractions are 7 to 8 minutes, lasting about 40 seconds. Yeah, so we have these different rationales here, but I'll just go ahead and read A. Remember, the latent phase is the first phase. Latent phase is the first stage of labor. It's the first phase of the first stage of labor involving dilation of 0 to 3 centimeters, effacement of 0 to 40%, and the contractions are about every 5 to 10 minutes, lasting 30 to 45 seconds. Next would be the active phase, going into 4 to 7 centimeters, 40 to 80%, and contractions are every 2 to 5 minutes, lasting about 2 a minute. So, okay. When in doubt, have them come in. Why, when the amniotic sac ruptures, the barrier to infection is now gone, and there's now danger for a cord prolapse if engagement has not occurred. The others increase the risk for infection and cord prolapse. Okay, so this one is saying it's the contraction from its onset into the highest intensity. So it was a hill, right? What would be the what would be A? Yeah. And then D would be the decrease. A and B are the exact same thing because acne is the peak. Client states, I think my water just broke now. I feel the fluid between my legs. The nurse tests the fluid with nitrazine paper and confirms that membranes have ruptured when the swab turns what color? Yes. Blake is caring for a woman during the 3rd stage of labor, which finding would alert the nurse that the placenta has begun to separate. Nice. Signs of placenta separation include a farm uterus, a change in uterine shape to a globular ovoid, and a sudden gush of dark red fluid from the vaginal opening. And that is it for today. If you guys on YouTube have not signed in, go to the beginning, and of course that will be right there for you.